Hello, everyone, and welcome to the 2025 Quarter 4 CE session. Our topics for review include altered mental status, seizures, ingestion, and poisoning. We will be reviewing the CCEMSA protocols for both paramedics and EMTs. Altered mental status. A few facts and stats. In 2024, American Ambulance treated 5,800 patients under the Altered Mental Status Protocol. This is a helpful protocol when attempting to rule out an unknown patient etiology. An overview of patient assessment. It is important to determine the patient's baseline mental status first. Consider if this is an acute onset versus gradual. Assess respirations, including the rate and rhythm, pulse rate and quality, skin signs, be alert for signs of shock, blood pressure, SpO2, and blood glucose level. It is important to rule out cardiac dysrhythmia or shock. If you are unsure, start treating for altered mental status until further assessment warrants a change in treatment or protocol.
AEIOU, TIPS, is a mnemonic that helps you remember which letters are vowels as well as the causes of an altered mental status. An altered mental status is something that's commonly encountered in medicine and has many causes, so knowing this mnemonic should help you in narrowing down the causes for your particular patient. To help you remember this more easily, most letters have two causes apart from the E, the I, and the U. Alright, so A is for one of the most common causes, which is alcohol or abuse of drugs. You always need to consider this when someone presents with an altered mental status, including prescription medications. A is also for acidosis, which often comes from things like diabetic ketoacidosis and things like hypercapnia, which is an excess of CO2 in the blood, which often comes from COPD, asthma, or a neuromuscular disease. E is our biggest list of causes, including environmental causes like hyper or hypothermia, epilepsy, electrolyte imbalances, particularly hyper or hyponatremia, and hyper or hypocalcemia. Encephalopathy is another, which may be acute, such as in Wernicke's encephalopathy, due to the body running out of B vitamins, especially vitamin B1 thiamine. This occurs often in alcoholics and more recently discovered people who've undergone bariatric surgery. Finally, we have endocrine causes such as adrenal insufficiency and thyroid disease. Our first I is for infections, so think sepsis, encephalitis, or meningitis. Often people will complain of a stiff neck and photophobia in meningitis. O brings us back to drugs, overdose. Again, you need to consider prescription medications such as benzodiazepines as well as overdoses on things like opiates. The other O is for oxygen. Often people can present with an altered mental status due to hypoxia. This can come from many different causes, but some common ones include pulmonary edema, pneumothorax, or an arrhythmia. Next, we have U for uremia, meaning an excess of urea in the blood. This comes from things like renal failure or congestive heart failure. T is for trauma, such as concussion seen often in rugby or NFL players, as well as things like cerebral hemorrhages. Also, we have T for tumours. I reminds us of insulin. If you take too much, you can end up hypoglycemic. If you don't take enough, you might end up in diabetic ketoacidosis, as we mentioned earlier. We also have intestinal causes under I, including intussusception and intestinal ischemia. Now we're on to P for poisons like carbon monoxide poisoning or lead poisoning. P is also for psychosis. Finally, we have S to remind us of strokes, but also to remind us of shock.
An overview of diabetes mellitus. Most type 1 diabetics are diagnosed early in life, while type 2 diabetes generally has a later onset. Type 1 is an autoimmune disease where the beta cells are attacked in the pancreas and destroys or degrades insulin production. Type 2 diabetes is normally caused by poor diet, obesity, alcohol abuse, and sedentary lifestyles. These contribute to insulin resistance or decrease insulin production. Both share the hallmark polys of increased thirst, hunger, and urination. Other signs and symptoms include unexplained weight loss, fatigue, slow healing wounds, and neuropathies like numbness, tingling, or pain in the extremities. So let's begin with hypoglycemia, which is the most common diabetic emergency we encounter. Both type 1 and type 2 diabetics are susceptible to hypoglycemia. The number one cause is medication errors. Not taking medications or taking them without eating is a big culprit. Exercise or overdoing it, or even the stressors of illness, can also contribute as well. Most diabetics need to follow a fairly close regimen of medications and calorie intake. Taking too much sugar or alcohol without longer-lasting carbs or proteins can lead to blood sugar dropping as well. It is often some combination of events that lead to these hypoglycemic episodes. Some signs and symptoms of hypoglycemia. The patient may be shaky and complain of a headache or blurred vision and be very hungry. Patients with hypoglycemia will often be pale, cool, and very diaphoretic. The irritation and alteration in mental status can present challenges to assessment and treatment. Hypoglycemia can often be mistaken for intoxication or a behavioral emergency if not ruled out with a blood glucose measurement. Hypoglycemia normally comes on very quickly within a couple of hours of the medication error or missed meal. Blood glucose readings will usually be below 80, but tolerance varies from individual to individual. Next up is hyperglycemia. The main condition is diabetic ketoacidosis, or DKA for short. This is most likely to develop over several days or even weeks. Symptoms may include extreme thirst and hunger, frequent urination, especially at night, weight loss, malaise or fatigue, or lethargy. And in the later stages, the patient will become very drowsy, which will lead to unconsciousness. As the patient's acidosis increases, they may begin to exhibit unusual breathing patterns. The most common is Kussmaul, a deep and fast pattern that is the body's attempt to blow off the ketones and lower the present metabolic acidosis. There may be a fruity odor to the patient's breath. Not all persons can detect this, so it is not a reliable indicator for DKA. Blood glucose reading will usually be above 300, but tolerance varies from individual to individual. Serial blood glucose readings that continue to persist with high values are the concern. A record of the patient's monitor may be helpful if available to establish this trend. Let's review some of the common drugs used to treat diabetes mellitus. Many new drugs are insulin helpers that are oral agents or weekly injections. Common oral agents include metformin or glucophage, glucocontrol or glipizide, diabeta or glyburide, and all forms of insulin, Reglan, Humulin, and Humalog. Many type 2 diabetics, after a time, will progress to insulin use as their disease progresses. As we begin to look at assessment and treatment, let's review our tool for blood glucose checks. This is the blood glucose monitor that we use on both ALS and BLS units. It is rated for using capillary, venous, and arterial blood for testing. It measures blood glucose in milligrams per deciliter between 20 and 600. If it reads low, it is below 20, and if it reads high, it is above 600. It is important to know these numbers as they represent extremes for our patients. Let's do a brief overview of the EMT protocol for altered mental status. Start with your assessment. Move on to securing airway and providing oxygen, high flow for altered mental status, and low flow for syncope. Naloxone if suspected opioid overdose with respiratory depression of a rate of 8 or less. Glucose monitoring, obtain a fingerstick blood glucose level, and if the level is less than 80 milligrams per deciliter, treat with oral glucose. Altered mental status, ALS protocol. As a review, we begin with the assessment, securing the airway, and appropriate oxygen therapy. Attach the monitor and determine the need for naloxone. Remember, the IN dose is 2 milligrams, IM is 1 milligram, IV 1 milligram. Establish IV access and obtain a fingerstick blood glucose level. Continuing with the ALS protocol, if your patient has a blood glucose level of less than 80, treat with dextrose, 25 grams IV. If you are unable to establish an IV, you can use glucagon, which is given IM or IN. For pediatrics, we are going to give 1 milligram per kilogram of D50 IV push to a maximum of 50 milliliters. If they are less than 2 years old, you need to dilute 1-to-1 with normal saline. Naloxone can reverse CNS depression caused by the following agents, both natural and synthetic: morphine, heroin, Dilaudid, Demerol, codeine, fentanyl, and hydromorphone. Indications for naloxone administration include ingestion and poisoning, only if suspected narcotic intoxication with altered mental status and respiratory depression. Adult dose is 2 milligrams IN, 1 milligram per nostril. You can give 1 milligram IM if you are unable to administer IN. You can also give 1 milligram slow IV push if no response to IN or IM administration after 10 minutes. The pediatric dose for naloxone is 0.1 milligrams per kilogram IN if less than 10 kilograms and less than 1 year old. Refer to the Broslow tape. Shorter duration of action than many narcotics. Repeated doses may be necessary. Monitor the patient closely on long transports. Medications for treating hypoglycemia. Oral glucose, 1 full tube, is 12.5 or 15 grams taken orally or rubbed into the cheek of an unconscious or semi-conscious patient. D50 is 25 grams of dextrose in 50 milliliters of solution, 1 amp per vial, which is the adult dose, or 250 mLs of D10, which would be the whole bag. D50 is 1 milliliter per kilogram D50 pediatric dose, or 5 milliliters per kilogram D10 from the bag. D25 is 1 milligram per kilogram D50, then dilute by half by adding an equal volume of normal saline if they are under the age of 2, or 5 milligrams per kilogram of D10. No need to dilute, and you can see the dosing chart included in your on-scene bag. Glucagon 1 milligram or 1 milliliter is reconstituted and can be given IM if you have no IV established. Pediatric dose of glucagon can be found on the Broslow tape. If you are using glucagon, oral glucose should be considered as well and used in conjunction. Every one of these therapies can be repeated in 5 minutes if the patient remains altered and has a blood glucose reading of less than 80. Some other methods for treating hypoglycemia include getting a patient to eat or drink to raise their blood glucose, but this should only be done when the patient is cooperative and appears stable. Start with sugary liquids and then move to more solid and long-lasting foods if you have success. It is important to get something with carbs or protein in the patient for longer-term care. Many of these patients do not want to be transported and will RMCT. Consider base contact, especially if you have done therapies or have a concern. An insulin-dependent diabetes mellitus patient that misses a meal may be a simple case, but a patient who takes an anti-hypoglycemic agent may have a more serious underlying problem. Normally, these patients should not drop in their blood glucose like the patient on insulin. Their hypoglycemia may be the result of sepsis, infection, or progression of their diabetes mellitus. These patients should be seen. Seizures. In 2024, American Ambulance ran over 4,600 calls where seizures was listed as the primary impression. Out of those calls, 740 patients were treated with at least 1 dose of midazolam. According to the CDC, 3.4 million Americans live with epilepsy. That includes 2.9 million adults and 456,000 children under the age of 18. A seizure is described as a sudden, uncontrolled electrical disturbance in the brain. Triggers include stress, both physical and emotional, trauma, and commonly poor medication compliance. Seizures can have several different etiologies, patient presentations, and durations. There are as many different presentations of seizure activity as brains having them. There are 4 stages of a seizure, which include the aura stage, the tonic stage, clonic stage, and postictal stage. Not all patients experience the same 4 stages of a seizure, and some may have a combination or absence of some of these stages. Febrile seizures are convulsions triggered by a fever in young children, typically between 6 months and 5 years old, and are often triggered by a rapid spike in body temperature. They are most commonly caused by fevers resulting from a viral or bacterial infection, such as the flu, roseola, ear infections, or a respiratory illness like RSV. In this video, we can observe the patient demonstrating tonic-clonic seizure activity.
Pop that on in, mate, and stick an airway in as well. Right.
For your seizure assessment, use FACS to obtain a quick history. F, focus, generalized versus local activity. A, activity, tonic-clonic versus abscene. C, color change, red, blue, ashen, which is a possible indicator of hypoxia. T, time, the length of the seizure. S, supplemental history of seizure, medication compliance, oral trauma, and incontinence. Now let's do a review of the BLS seizure protocol. We start with assessment and securing the airway, oxygen decisions including high flow for status epilepticus, obtain vital signs including a glucose monitoring, oral glucose if altered mental status more severe than disorientation to time or date, and if blood glucose is less than 80. You may repeat in 5 minutes if altered mental status persists, and repeat if the fingerstick is less than 80. Passive cooling for febrile seizures include removing the clothing. As a reminder, minimize your on-scene time, and if you need ALS rendezvous, request it early. ALS protocol for seizures starts similar to the BLS protocol with assessment, securing the airway, and oxygen decisions. Apply the monitor and be prepared to administer midazolam intranasally at 0.1 milligrams per kilogram to a max dose of 4 milligrams. Administer half in each nostril using the MAD device. Establish IV access, a saline lock for a first-time seizure except for a pediatric febrile seizure, prolonged focal seizure, or recurrent seizures. Midazolam intravenous. If the seizure continues, administer 0.05 milligrams per kilogram slow IV push over 2 minutes, 2 milligram maximum per dose. You may repeat once in 10 minutes. If given intramuscular, 0.1 milligrams per kilogram to a max dose of 4 milligrams. May not repeat without base hospital contact. Obtain an AccuCheck and be prepared to give dextrose if the patient is hypoglycemic. Magnesium sulfate given in 5 grams in 250 mLs of normal saline over 20 minutes following midazolam to stop the seizure, if in late pregnancy and hypertension or late pregnancy with no prior history of seizure disorder. Transport and minimize on-scene time. Stat transport if the patient is unstable. Midazolam is a short-acting benzodiazepine CNS agent, sedative hypnotic, and anticonvulsant. The indications include seizures. Adult dose intranasal is 0.1 milligrams per kilogram to a 4 milligram max. Administer half in each nostril. Intramuscular, 0.1 milligrams per kilogram if no IV access, again to a 4 milligram max dose. This route may not be repeated without base contact. IV is 0.05 milligrams per kilogram, slow IV push over 2 minutes to a max dose of 2 milligrams. The pediatric dose is the same as the adult dose. Magnesium sulfate 50%. The class is an anticonvulsant and electrolyte replacement. Indications include eclampsia or seizures. If late pregnancy with hypertension, midazolam to stop the seizure prior to MAG. The adult dose for eclampsia includes 5 grams and 250 cc's of normal saline, IV infusion over 20 minutes. Moving on to ingestions and poisonings. Overdoses can come in many shapes and sizes, including natural plant substances, household products, dietary supplements. Prescription medications, even over-the-counter medications, can be lethal. Not all ODs are intentional. Some may be accidental or a case of poor compliance due to medication schedule. Exposure to substances at work or around the home can also result in a poisoning. A common poisoning that you may run into is an organophosphate poisoning from insecticides, pesticides, and herbicides. These can present as both challenging patient and potential risk to EMS. Until the source of the exposure is determined and isolated, care should be taken. Many of these substances can be absorbed through the skin. Look for signs of sludge, salivation, lacrimation, urination, defecation or diarrhea, gastrointestinal cramping, excessive sweating. Often, these patients will be bradycardic as well. These patients are having a cholinergic crisis. Anticholinergic toxidrome. Some drugs include atropine toxicity, and Benadryl overdose can cause the opposite of sludge and exhibit signs of anticholinergic crisis. Some plants like belladonna, deadly nightshade, and Jimson weed can also cause these same effects. People have been known to harvest and smoke the seeds of Jimson for recreational experience. The little rhyme above does a good job explaining the signs and symptoms. Blind as a bat, dilated pupils. Mad as a hatter, confused, even hallucinations. Red as a beet, flushed skin. Hot as a desert, dry as a bone. Hyperthermic and dehydration. Here is a 12 lead from a tricyclic overdose patient. Tricyclic ODs are not as common as they once were. This class of antidepressant has been replaced by other not-so-lethal medications. Amitriptyline and nortriptyline are a few common names. These are primarily used for depression, but can be used for insomnia, migraines, and neuropathies. Cardiac arrhythmias, including widened QRS-T abnormalities and tachycardia, as well as hypotension, seizure, and coma, are common. Here is a short video of a dystonic reaction.
Trouble talking. Early this morning, count to 10 for me.
1, 2, I do. I feel better. I feel like I can talk.
I'm gonna download level on as well.
I said what I want to say now.
Alright.
I feel better.
A review of the ingestions and poisoning BLS protocol. Start with ABCs and oxygen choices as appropriate for patient presentation. Position the patient on their side if they are altered, and locate any containers or any other substances that might indicate the reason for the patient's altered presentation. Ingestions and poisonings ALS protocol. Start with assessment airway, and oxygen choices, treat the rhythm if appropriate, establish IV access, and transport to the hospital. If suspected hazmat incident, initiate decontamination and contact base hospital immediately. Base hospital orders include sodium bicarb and atropine. Sodium bicarb is 1 milliequivalent per kilogram IV push over 2 minutes. Atropine is 2 milligrams every 5 minutes and as needed. A review of sodium bicarbonate. It is an alkalotic agent and an electrolyte. Indications include tricyclic ingestion with life-threatening dysrhythmia. The adult dose for tricyclic ingestion is 1 milliequivalent per kilogram IV over 2 minutes. Atropine is an anticholinergic, antiarrhythmic. Indications include organophosphate poisoning or nerve gas poisoning. The adult dose is 2 milligrams IV push every 5 minutes. You may increase to 5 milligram increments every 5 minutes if no response to the 2 milligram increments. This is a base hospital order. Our last drug for review is diphenhydramine. This is an antihistamine. The adult dose is 50 milligrams IV push over 1 minute, or IM if unable to establish an IV. The pediatric dose is 1 milligram per kilogram slow IV push, or IM, to a max dose of 50 milligrams. Use in anaphylaxis and phenothiazine or dystonic reactions. That's all, folks. Thanks for your time and attention today. Stay safe out there.